You know, what this reminds me of is we so frequently throw the baby out with the bathwater in treating patients based on the name of their disorder rather than much understanding of the mechanism in that given patient. I recall many years ago I was on an NIH advisory board that was, this many years ago, looking at the treatment of aplastic anemia. And one of the arms was going to be steroids. And many of us pointed out, including myself at that point, that aplastic anemia is probably multi-causal. Of course it is. It's an end-stage kind of process, and 70% later on were demonstrated to have immunologic damage, and steroids might be particularly efficacious in that group. But now let's do a study, and you take 100 patients with aplastic anemia, and only a subgroup are going to be responsive to immunosuppression if you rationally knew that that was the group who was being immunologically, where marrows were being immunologically attacked. You would lose the benefit in a statistical study of immunosuppressants in 100 patients because 30% didn't respond whatsoever. And I think probably what you're telling us is the same in lung cancer. There's going to be multiple different mechanisms of somebody having a lung cancer. And as we define those, we might well be able to come up with a rational tyrosine kinase inhibitor for this particular mutation and not do a huge study that would not demonstrate efficacy because we have 80% of the patients who don't happen to have that problem. It would be a little like treating all leukemics with Gleevec. 50, 70 years ago, Gleevec would not be statistically very helpful.
No, I agree with that, and we actually have a good clinical example of that. More and more we're realizing that lung cancer is not a single disease, but a group of diseases typified by different histologic features, typified by different markers, typified by different expression of phenotypic aberrations. An example that is in harmony with your aplastic anemia was the testing of the first generation of the tyrosine kinase inhibitors as part of chemotherapy without looking carefully. And the 10% or so response rate that's likely to have benefited in the population is lost in the overall population. An analogy would have been to test Herceptin without looking at the HER2 nuke expression. And that's I think the most exciting part of solid tumor oncology today is that more and more we're beginning to understand the differences in the subtypes of disease. And I actually foresee a time when the specific histology will be less important than understanding the phenotypic expression of the genotypic aberrations that will actually define the therapeutic alternatives.
I completely agree. Do you have an example in lung cancer at this time of a signature, a genetic signature, which at this point is good enough to tell us that we really have to be much more aggressive in this given patient with that signature compared to 50 other patients without that signature, that one might be able to save them a great deal of toxicity, not only from drugs, but radiation, et cetera?
I think we're just at the front edge of this. So
give us an example. Do you have is there, I don't mean what exactly the signature is, but you're saying that it may be worthwhile, at least in a clinical trial kind of way, to really document certain signatures and say, okay, we're going to go with more or less therapy based on that?
Well, I believe so. Let me give it on stages. So we know that squamous tumors tend to be much more loco-regional than are their counterparts in adenocarcinoma or poorly differentiated carcinoma. So for stage 3 disease, adenocarcinoma, the local therapies have had more of an impact really than some of the systemic therapies, and that was witnessed in the South study where hyperfractionated radiotherapy by itself did almost as well as the combined modality. If we look at the genetic component to this, in the large European IALT adjuvant trial, when they went back and looked at that and assayed the tumors for ERCC, they found that those tumors that expressed ERCC did not benefit from adjuvant therapy at all. And there have now been 2 well-conducted prospective studies that had looked at this expression and found that if you sort out or eliminate from the population those patients whose tumors express this profile and not treat them with platinum, you then enrich the group that's receiving the platinum-based therapy for response and duration of response.
Last question. Are there clinical trials that have been started in which the genome of the tumors are a part of a breakdown of what to do and what not to do?
I think that we're just, part of the problem, particularly in advanced lung cancer, is tissue acquisition. Because a lot of times these are diagnoses made from fine needle aspirates. It's very hard to get total profiles on those. So the samples that we're using are relatively selected population, if you will, where adequate tissue samples are available. But we now have the technology, and we need to bank tissue as the technology continues to grow for us to be able to look at not just specific one gene signatures, but the profiles of the gene patterns, if you will, the gene maps, so that we can begin to understand the interplay of these various substances. And we will break lung cancer into a family of diseases for which we can pick different therapeutic options.
Joe, I thank you so much for not only participating in this program, but for being a superb section editor of lung cancer for Hem-Onc Today.
Thank you.
Thank you for watching this video from Hem-Onc Today. Keep up with all our new videos by visiting the Hem-Onc Today YouTube channel or go to our website at hemonctoday.com.